Our second speaker today is Dr. Tara Henderson. She's an MD, MPH, an associate professor of pediatrics here at the University of Chicago. Her clinical expertise, she's a pediatric oncologist, but I was just asking her because I knew her academic and one of her clinical areas of focus is survivorship after pediatric malignancy, but she also specializes in treating pediatric lymphoma. She's published extensively on the late effects and the long-term effects of childhood cancer treatment. And she'll, I think, talk about that with us today. So I'll turn it over to Dr. Henderson.
Yeah, thanks so much, Dan. It's great to see or not see medical students today. I'm sorry that you're missing some of your education. I'm a Pritzker grad myself, and I think that it was just a tremendous place to start my medical career, and I enjoy coming to do this lecture every year. As Dan said, I do survivorship. I've focused in the pediatric and AYA world, and actually now I am helping the Cancer Center do survivorship for all of our cancer center. We just started a breast cancer survivorship program, and we're trying to expand that beyond to all of our tumor types. So to try to achieve somewhat what Carol's been doing for many, many years. So what I'm going to be talking about today is perfecting cures through survivors, which is really a pediatric oncology story. So I want to describe to you a model of research that we use to examine cancer outcomes and survivorship, which then links back to how we improve care. To describe the outcomes in healthcare specifically of childhood cancer survivors using breast cancer as an example, and sort of how to describe how optimal therapies for pediatric and AYA cancer are informed using Hodgkin lymphoma as an example. And then I can talk a little bit about our program that we've informed by outcomes research. So when people ask me about why I'm a pediatric oncologist, I always say I want to have at parties this slide, because sometimes when I go to social pre-COVID, when you're in a social situation, people ask me what I do. The reactions are remarkable. They either kind of back away or get sad. And I said, well, no, like this is one of the greatest fields in medicine. We've gone from curing patients in the 1960s, less than 10% of our patients were cured. We're actually quoting almost 85% of our patients diagnosed with cancer before the age of 21 will be cured for life. And this is because of laboratory discovery. We have more intense therapies, so our patients can tolerate a lot more chemotherapies than our adult counterparts. We are really fortunate in pediatric oncology to have a very collaborative group of providers. So when you look overall at patients enrolled in clinical trials in adult oncology versus pediatrics, in adult oncology, less than a third of patients are actually enrolled on a clinical trial, whereas in pediatrics, almost 75% are enrolled in a clinical trial. And that is because of our collaborations nationally and internationally through cooperative groups. So our cooperative group is called the Children's Oncology Group. We've also made tremendous advances in supportive care, antimicrobials, anti-nausea medicines, et cetera, as well as we've been on the cutting edge of new therapies with stem cell transplant, targeted agents, immunotherapy, including CAR T cells, as well as PD-1 inhibitors, which you may have heard already in your course. So as a result of this, childhood cancer survivors have really become a focus of both national and international attention. There's been significant lay press talking about this growing population, but also showing that there's a cost to cure. Now, I want to describe to you this model that I'm going to be going through and kind of refer back to. So as we have this growing population, we have cancer survivors here. If we can study these survivors, we'll learn more about their health-related and quality of life outcomes that Carol mentioned a little bit about. And knowing who has these outcomes enables us to identify high-risk groups. We take high-risk groups, and then you can use that for their future healthcare to develop evidence-based guidelines for these high-risk cancer survivors. We can also develop interventions to mitigate these long-term effects of in cancer survivors, both physical and emotional and socioeconomic. I know you, Carol just mentioned financial toxicity, which is a huge area. And then we can have these trials where these interventions can be implemented and disseminated. But overall, all of these outcomes can then be taken to upfront cancer diagnosis and treatment, so that when we treat patients, we're not just looking for a cure, but we're thinking about perfecting the cure and thinking beyond 3 and 5 years. So when I talk about there being a cost of the cure, we've had the advantage in pediatrics that we have large cohort studies in the US. One that I'm going to refer to frequently is called the Childhood Cancer Survivor Study. So this is a study that is based out of St. Jude Children's Research Hospital, but includes the patients from 29 institutions in the US and Canada. And between 1970 and 1986, we followed 14,000 of these survivors. Excuse me, since 1994, we have followed 14,000 of these survivors diagnosed between 1970 and 1986. We follow them with questionnaires, we have biologic samples from them, we recontact them frequently, and we have now almost 600 publications from this cohort. So what we've learned is that 30 years after their cancer diagnosis, 75% of them have at least one chronic health condition, and 2/5 have a severe or life-threatening condition. And these conditions are eight times more likely, these patients are 8 times more likely to have a severe or life-threatening condition than their siblings. As a result of this, these patients have significant late mortality. So let me just describe to you what this is. This is standardized mortality ratio. So this is basically your death rate compared to the general population. So what we did was take the rate of death in the childhood cancer survivor study. So these are the survivors that are women and these are men. And we age match them to the general population. And so this again is women and men. And you can see that in their time since diagnosis, they're dying at almost 11 times the rate of the general population. And we know that this is foremost due to new cancer, so not relapse, but actually new primary cancers, as well as cardiac and pulmonary disease. My colleague at Dana-Farber actually took this same data and said, well, what does that kind of mean in terms of your life expectancy? And so she looked at mortality probability of these same childhood cancer survivors in the Childhood Cancer Survivor Study and compared them to the US population. And so basically what she found is there's a 10.5-year loss of life expectancy for these patients due to all these chronic health conditions. So I want to use Hodgkin lymphoma. Dan was asking me in a break what my clinical expertise is, and it's actually Hodgkin lymphoma and lymphomas. So I wanted to talk a little bit about Hodgkin lymphoma because this is a disease that cures have been driven through our understanding of childhood cancer survivors. So just a little bit of history. A pathologist named Hodgkin in 1832 first described this disease when he was looking at removed glands and spleens from patients that had died. And he wrote us a paper called On Some Morbid Appearances of the Absorbent Glands and Spleen. And shortly thereafter, like 60 years later, Sternberg and Reed first did their definitive and thorough descriptions of the pathophysiology of Hodgkin lymphoma. And I don't know if you remember, I didn't put a picture here, I apologize. The Reed-Sternberg cell, I remember we looked at it first as second years at Pritzker in our CPP class, but it's the classic sort of owl eye appearance of the two Reed-Sternberg cells. So the epidemiology of Hodgkin lymphoma, we see about 12.1 cases per million. There's about 850 to 900 cases per year under the age of 20 in the United States. We see it a little bit more often in women. We see it more often in white patients. And it represents about 7% of childhood cancers less than 20 years of age. And actually this is this should say 15 to 19 years, but 16% of our adolescent and young adult patients, 15 to 19 years. So in terms of our first successes with treatment, in the early 1900s, our first attempt to treat these patients with radiation was kind of dismal, but then we continued to do better with radiotherapy, and that resulted in our first treatment improvements. In 1940, one of the byproducts of the wartime work with mustard gases, so that was something that were used for chemical warfare, but while they were studying it for chemical warfare, they were also using it back in the laboratory to understand what we could use it for in medicine. They saw that there was a powerful lymphocytolytic effect. And so they started to think perhaps we could bring this mustard gas into therapy for cancer. In 1964, the studies with multi-agent chemo led to MOP therapy, and we started to see about a 50% cure rate. And this evolved in the 70s to start using ABVD chemotherapy, which is a backbone that we use now. It's adriamycin, vinblastine, bleomycin, as well as dacarbazine. The concern with using this chemotherapy were cardiac outcomes, which I can get to in a little bit. So as you can see here, between the 70s and 90s, we really started to see increases in survival where we were curing these patients almost 95% of the time. So we started with this high dose extended field radiation. So basically the radiation field went up above the neck to below the diaphragm. And we would give this chemotherapy called MOP, which included a lot of alkylator chemotherapy, as well as surgical staging, which meant basically we would remove the spleen from these patients because the Hodgkin's often hides out in the spleen. So all of these patients would get splenectomy, and they would slice through the spleen like it was a loaf of bread to see if disease was there. In the 80s, we started move toward involved field radiotherapy at lower doses with alternating chemotherapy in between, and used clinical staging instead of surgical. And we've evolved to more a risk and response-based approach. We've really moved away toward gender-directed treatment, but early on in this period, there were some regimens that were more associated with infertility in men. And so we would be careful to avoid certain therapies with them, and we would then use a separate one in women. So one of the first things we started seeing in Hodgkin lymphoma that really changed the therapy was growth impairment. So you could see that there was, with this mantle field radiation, younger patients who got these high doses would have, their body wouldn't grow. You would have, the spine wouldn't grow. You would see decreases in muscle mass in these patients. And I think you can see here that the growth of this patient reflects where their radiotherapy was. The other significant late effect after Hodgkin lymphoma, which you may have heard about, is breast cancer. So this was first described in the early 90s, and we started to see that these patients treated with the radiotherapy for their Hodgkin lymphoma were having high rates of breast cancer. And this is one of the areas of focus of my own outcomes research. So I think this is a really interesting study. This was from the mid-90s, and my colleague Smita Bhatia went to a cohort study that preceded the childhood cancer survivor study that I mentioned to you, called the Late Effects Study Group. And she looked at 1,380 Hodgkin lymphoma survivors who were treated with high doses of radiotherapy. And she found that 2,000 gray of radiotherapy was associated with a 6 times risk of developing breast cancer. So you can see by the age of 45, the risk of developing breast cancer was almost a third. So that's sort of remarkable. That's higher than women that carry a BRCA1 or 2 gene mutation. We then went to the childhood cancer survivor study about 8 years after that, and we decided to look at not just women exposed because of Hodgkin lymphoma, but looked at all childhood cancer survivors. And again, we showed that these patients had high rates of breast cancer. This is our rate here. We looked at, these are the patients with radiotherapy, and these are actually the patients that didn't get radiotherapy, which showed that these patients, even without radiotherapy, had high rates of breast cancer. So again, here's that mantle field that I was telling you about, which we've now gotten away from using, that includes radiotherapy up to the ears and below the chest. And it also included over here, which was a significant issue, the axilla, putting a lot of the breast tissue in the field. From the mantle field, we moved to the involved field, or the mediastinum, for treatment. This was used both for Hodgkin, non-Hodgkin neuroblastoma. The therapeutic doses ranged anywhere from 1,500 to 3,500 gray. And you no longer had the radiotherapy that was in the axilla. So my colleague wanted to see, as we started to move away from these different fields, and as time moved along, we thought dose was a real issue. We wanted to see if dose was related to the risk of developing breast cancer. And so he went into the childhood cancer survivor study, this elegant study that showed that there was a linear association with the development of breast cancer by the dose of radiotherapy that you received. And around the same time, I'm going to move my picture of people. Around the same time, sorry. Take my wallet, it's right here. Sorry, I took my husband's wallet and he's going to get our dinner. Okay, so around the same time, my Dutch colleagues decided to look at not dose, but actually the field that you received. And so this yellow line is mantle field and the blue line is mediastinal field. And you had a decreased risk in developing breast cancer based on the field you received. We then wanted to go back around this time in the early 2000s to the Children's Oncology Group in response to the Institute of Medicine, which I'll be repeating again in a few minutes, decided that we needed to provide risk-based healthcare to all childhood cancer survivors. In response to that, the Children's Oncology Group had recommended that we develop surveillance guidelines and wrote significant detailed surveillance guidelines for all childhood cancer survivors based on their exposure. And so we wanted to update the guidelines for the Children's Oncology Group in around 2010. And so we decided to do a systematic review of the literature to really understand what was the incidence and excess risk of breast cancer after chest radiation, what were the clinical characteristics and outcomes following breast cancer, and really what was the harms and benefits associated with screening in this population. So what we found was the median age is very young. So basically these patients are being treated in their teen years, 12, 13, 14, and the interval from radiation to breast cancer was short, 10 to 20 years. So we were starting to see breast cancer in these patients as young as 25. We were seeing it in the upper outer quadrant as well as the inner quadrant of the breast. And we found that there were very high rates of bilateral breast cancer, so about 26%. Which is more consistent with patients who carry genetic risk for breast cancer, not with garden variety breast cancer. And we were finding that 55% of patients who had a bilateral went on to have a bilateral mastectomy at their time of diagnosis. We also learned that 5-year survival was strongly associated with stage of diagnosis. So basically women with early stage disease have good outcomes. But we were worried about limitations in therapy. So can these women get more radiation for their breast cancer? What about anthracycline chemotherapy? This is a mainstay in the backbone of breast cancer treatment. And this can impact the function of the heart with high cumulative doses. And how are we using that for breast cancer? So in response to this systematic review, we actually published the Children's Oncology Group guidelines recommending annual mammogram and breast MRI starting at age 25 or 8 years after exposure to chest radiotherapy. Subsequent to that, we started looking even further into this population. My colleague Kaya Moskowitz and I she has had an R01 funded study to basically build a risk prediction model for childhood cancer survivors and breast cancer risk. So I don't know if you've learned about the GALE model yet, but the GALE model is a risk prediction model for breast cancer used in the general population that you enter a patient's risk factors. So their age, their family history, whether they're drinking, their BMI, and this all goes into a calculator and it spits out what your risk of developing breast cancer is. So Dr. Moskowitz is trying to do this in childhood cancer survivors, but in addition to all the risk factors for breast cancer, the general population, she also wants to look at exposure to chemotherapy, exposure to radiotherapy, and other treatment-related risk factors. And so we went back to the childhood cancer survivor study and really dug into the risk of exposure to radiotherapy and wanted to look at the difference between developing breast cancer in this population and other high-risk population cohorts. So she actually went to SOAR. So SOAR is Statistical Endpoints, Epidemiology, and Risk, which is a consortia of 3 cancer registries in the United States that tells us what the population rate of cancer is in the US. It's used all the time. And then she looked at a cohort of BRCA1 and 2 carriers. And then we were able to look at breast cancer compared to them. So you can see here, the blue line is our Hodgkin lymphoma survivors. And again, we're seeing really like 40% of them are developing breast cancer by the age of 40. But importantly, these Hodgkin lymphoma survivors are getting rates of breast cancer probably equivalent to BRCA1 carriers, but much higher than BRCA2 carriers, which tells us this is an extremely high-risk population. We were also interested, because I don't know if you remember a couple slides back, that our initial breast cancer screening guidelines really only included women exposed to over 20 gray of radiation. And so we had started to note clinically, like when we were in survivorship clinic, that these patients who got lower doses, so 10 to 19 gray, which includes patients that had whole lung radiation. So Wilms tumor is a kidney tumor that we see in childhood. And when it's metastatic, we give these patients whole lung radiation. Also, some sarcoma patients would get whole lung radiation. And then the other patients who are in this 10 to 19 gray category are patients that get total body irradiation. So no one really understood, what is the risk for these patients? Well, what Haya and we found was that the risk is high. So standardized incidence ratio is the risk of developing a cancer, but and the way we compare it to the general population is we compare age and sex match rates to that SOAR registry that I mentioned to you, the general population cancer registry. So we could see that these patients that got 10 to 19 gray of radiation were getting breast cancer 30 times the rate of the general population at the same age, which is even higher than these ones with higher doses who are getting over 20 gray of radiation. So really we're seeing that any dose of radiation to the breast at a young age is associated with extremely high rates of breast cancer. We, again, were showing, similar to before in this data, that field mattered. And, I think what we really showed here, this is that whole lung radiation was as a higher risk as the mantle radiation that I had showed you previously. And this basically goes over that the whole lung radiation has a risk of about 40-fold that of the general population. So I wanted to show you a study that we did more recently. So a question people ask is, okay, so this looks like garden variety pathologic breast cancer, but they're getting it young and we're screening for it, but are they dying from the breast cancer at the same rate as the general population, or are they dying more? What happens once these patients are diagnosed with breast cancer? And so Haya and I went and looked at 274 women who developed breast cancer after childhood cancer, and then we compared them to almost 1,100 women who developed de novo breast cancer in the general population. And so what I want to show you is that the mortality rate in general of breast cancer was slightly elevated. It was 1.3, so times that of de novo breast cancer. But what's really important here is that these women were more likely to die of other health-related causes. So you can see here overall, the childhood cancer survivors are dying faster than the general population, but it's not because of breast cancer. It's because these other causes that I mentioned to you earlier. They're dying of other second cancers, cardiovascular disease, and pulmonary disease. And I think that this is just such a remarkable finding, because it really shows us that these patients need to be taken care of by doctors who are really aware of the therapy they went through before. I think this course that Dan is providing, you're actually going to be some of the doctors that really are keyed in to some of these special populations. Are going to be able to really be armed to take care of them well. So I'm really thrilled to know that you're interested in learning about these populations, because I'm going to show you that not all physicians are keyed into this this significant disease in cancer survivors. I'm going to move my thing over here. So I want to get back to Hodgkin's. So today, 90 to 95% of all children and adolescents with Hodgkin's can be cured. We use multi-agent chemotherapy and short pulse dose cycles. I actually, this is a typo, because I really don't even think we're using involved field anymore. And Dan, maybe you could jump in on that, but really we're using involved node or involved, and our new clinical trials are using involved site. We're not really using proton therapy in Hodgkin lymphoma, but we really are trying to think about how to direct radiotherapy to minimize late effects.
Yeah, just really quick. So they actually are looking at, I mean, most kids now would get proton therapy if it's available.
Really?
Yeah. And
our trials, most patients are not getting it.
That might be I mean, it's still only often available in urban areas with proton centers. There's like 20 in the country right now. So a lot of children might not be traveling.
Right.
Like in Chicago, I don't think we would treat them with x-rays. It depends slightly on the site, but also to your point, yeah, I think a big thing to point out is the fields, even what you showed going from mantle to mini mantle to mediastinal, is still much larger than what we treat now. These very focused fields that just treat the involved node or involved site, because we know the volume we treat with radiation significantly increases the risk of late effects. So.
And I think my adult colleagues are trying not to give them radiation at all. So there's a trial. What'd you say?
It hasn't worked.
It hasn't worked.
So we're still treating with radiation. There have been a few trials looking at removing radiation, and so far it's still the standard.
Well, right now the high-risk study that's open through SWOG is a comparison of Nivo ABVD versus brentuximab ABD, and then only radiating the areas of bulk disease. We're trying with intermediate risk therapy to really get away from using radiation, and it's really interesting in having these conversations with our radiation oncology colleagues and medical oncology colleagues. And I think you highlight this, Dan, is that there are patients that still need radiotherapy, and I still have medical oncology colleagues resistant to that. And we're seeing in pediatrics that there still are patients that need radiotherapy and cure them. And I think that it's okay. Like, the point is to cure these patients. And the fact of the matter is, we're so fortunate that we understand these late effects and we now can follow them lifelong, that I think that we have to think about all of this when we're treating a patient. So I want to talk a little bit about Hodgkin lymphoma survivors, because again, when we have a new patient, when we think about treating them, as I showed you, about 95% of them are cured. So their long-term survivorship care is equal to think about at their diagnosis as their initial therapy. So as I mentioned, there's been 2 calls to action by the Institute of Medicine. In 2003, they had recommendations for risk-based healthcare to monitor for cancer reoccurrence, surveillance and intervention for late effects and second cancers, and then prevention and education. So basically teach the survivors about their previous care, educate them about long-term healthcare, and then to help them with all their psychosocial and financial challenges. And then as a result, we developed long-term follow-up guidelines that any of you can go look at survivorshipguidelines.org, which have 166 sections detailing exposure-based late effects and screening recommendations. We grade the evidence. There are second cancer screening for both standard and high-risk groups, and there's also health links to give the families and the patients about their follow-up care. So importantly, we continue to update these guidelines. We had updated them so anyone exposed to chest radiotherapy gets breast cancer. And actually, I apologize, we had changed this to 10 gray and it's now any radiotherapy. And then the question is, are survivors receiving risk-based healthcare? Hold on one second. I'm giving a lecture. Okay. Sorry, that was my 6th grade son. You're getting to meet my whole family.
Yeah, last week they met my kids, so.
Sorry about that. I have my husband's wallet here somewhere too. Anyway, so the question is, I've shown you that there's all these long-term health issues, some of which can be impacted by screening. And then the question is, are they receiving risk-based healthcare? So in the childhood cancer survivor study, a few years back, we went to 8,500 adult survivors of childhood cancer, and then we asked them about their health care in the past 2 years. We found that only a third of them were receiving risk-based care. 56% were just going to a PCP but weren't getting risk-based health care, and then 12% were getting no health care. Importantly, 85% of childhood cancer survivors are getting cared for by a primary care doctor, and less than 15% are coming to the cancer center, to a place like where Dan and I work. And I think this is a remarkable graphic that shows when you get further and further away from your cancer diagnosis, you're getting all of these chronic health conditions. But then the doctors who understand these health conditions you're not seeing them anymore. The further they get from therapy, the less likely they are from going to the cancer center. And this is another interesting slide. We looked at those who are getting community care versus those who said they were still going to a long-term follow-up program or the cancer center, the gold standard. So you can see that in 64% who are going to the community doctor were getting good general medical care. But when you wanted to see survivor-focused care, whether they got an echocardiogram for exposure to adriamycin or a mammogram at an early age due to chest radiation, they were getting it more often when they were associated with the cancer center. So general health care appears to be delivered more in the community, while risk-based health care, including tests associated with long-term follow-up, are more often provided at the cancer center. So then we wanted to find out more specifically, are they receiving exposure-specific surveillance based on the guidelines? And this was an interesting study that we did in the childhood cancer survivor study, where we looked both at patients at average risk, so women that didn't get chest radiation, and just women in general, to see if they were getting standard breast cancer screening over the age of 40 or a pap smear every 3 years over the age of 21. And then we looked at high-risk survivors, those at the time were getting more than 20 gray of radiation, those at high risk for colorectal cancer getting over 30 gray of radiation to the abdomen, pelvis, or spine, or those at high risk for skin cancer, those getting any radiotherapy. And so importantly, you can see here for those at average risk, they were doing a pretty good job with getting those mammograms and pap smears. About 2/3 were getting their mammograms and 81% were getting their pap smears. Where we have a problem is with these high-risk patients. Only 12% were getting recommended colonoscopy, less than 50% were getting their mammograms, and only 1/4 were getting skin exams. We went to those women, as I mentioned to you, breast cancer is an area that I'm particularly interested in, and we wanted to know more because we wanted to develop intervention studies to make sure that these women were getting the breast cancer screening they needed. So went back with an additional survey to the childhood cancer survivor study to women exposed to chest radiotherapy to ask them about their screening practices. And this is the results of that. So you can see here's the women getting chest radiotherapy. The blue is women got no chest radiotherapy, and the siblings in comparison. And so you can see that they're a little bit higher than the general population, but what you want to look at is these women less than 40, right? Because this is the age group from 25 to 40 that are high risk and should be getting screened, and really they're not getting screened at high rates. So sorry, I didn't show you that slide, the highlighted with my cursor, my apologies. So basically, survivors are compliant with population-based screening, but they're not compliant with treatment exposure-based high-risk surveillance. And we think that this is a lack of knowledge and not a lack of motivation. So we looked at predictors of who were the women actually getting the breast cancer screening. And the only factor that was a physician recommended that they do the screening. So you needed to have knowledgeable physicians about this population. So early when I came to the University of Chicago, this was an area I wanted to look at. I said, are physicians aware of these long-term follow-up guidelines for survivors? So I partnered with a survey lab at the University of Chicago, and we decided to do nationally representative surveys of every pediatric oncologist in the United States. We surveyed about 2,200 family physicians in the US and Canada. And we surveyed almost 2,000 general internists through the American College of Medicine. And as part of this survey, we did a little vignette and it's about concordance with the guidelines. So we asked, CL was a 29-year-old treated with Hodgkin's disease when she was 16. She could receive combination chemotherapy, including adriamycin and cyclophosphamide, as well as mantle radiation. And we asked questions regarding cardiac screening, thyroid function screening, and breast cancer screening. Oops, sorry. And so what I want to highlight here, the blue bar is breast, red is cardiac, green is thyroid, and 3 is whether they were all concordant with these questions. So it looks like no matter what, people were good with ordering thyroid function tests. The pediatric oncologists were a little better than the others, but we developed these guidelines, so I would actually hope that the numbers would be even higher. But what it's important to see is that the family physicians and the internists were not aware of these breast and cardiac surveillance guidelines. In fact, less than 5% of both family physicians and general internists were concordant with all 3 of these guidelines. But another thing that's important is that most of these physicians were not caring for a lot of these patients. They only see like a handful of them in their practice. And they say they're not really comfortable with them. They don't really know the guidelines. They don't want to take care of them independently, but they're willing to take care of them. So basically what we learned from this is that the primary care doctors want to partner with the cancer center. They want to have, I think Carol talked to you about a survivorship care plan, which is basically a summary of their treatment and recommendations for follow-up. They want to have access to a treatment summary like that, and they want to know how they can call us at the cancer center if they need to. So how do we overcome these barriers? What Dr. Su, my fellow at the time, he's now an attending at Loyola, described these needs that I just mentioned to you. But then the Institute of Medicine also recommended this survivorship care plan. This was their recommendation in 2006. This actually, I should remove here, their mandate from the American College of Surgeons, the Commission on Cancer that accredited all cancer centers, that they recommended survivorship care plans for all survivors. There's been issues with this actually, where we haven't been able, no cancer center really has the resources to provide this care plan to every patient. And so we've really backed off on this mandate, but I still think that it's an important thing to provide survivors at the end of care. There's all ways to make these care plans, and actually Epic is working out ways to develop care plans, although it's easier said than done with the medical record. One of the problems is sometimes patients are getting their radiotherapy at one site, getting their chemo somewhere else, getting their transplant somewhere else, and it's not all in one medical record, and communications between doctors is something we need to work on. So what we learned is less than 20% of those primary care doctors that we surveyed actually received a treatment summary or care plan. We also need to do funded intervention studies. So I want to talk to you about one of them that we've completed. We have the Empower study. We have Empower 2 that's actually been in, and I just had another intervention study funded by the NIH. So let me talk to you a little bit about this. And I apologize again, this is now, was published last year in the Journal of Clinical Oncology. So this is an R01 study, funded study For women exposed to chest radiotherapy for a childhood cancer, we did an intervention to promote breast cancer surveillance in these patients to ultimately improve morbidity and mortality. So there were 330 women at risk who've never had breast cancer, did get chest radiotherapy, hadn't had a mammogram in the past 2 years. We randomized them to attention control versus this telephone delivered intervention. And the primary outcome was a report of a mammogram, because this was funded around the time that we were switching over to just mammogram for breast cancer to mammogram plus MRI, but looked at other secondary outcomes, including if you had an MRI, mediating and moderating factors to having screening, what were your barriers, and the economic analysis. So importantly, we showed here that we did show an increase in mammogram rates in this population with this motivational interview. But what was remarkable is we did not increase the rates of mammogram in this population, breast MRI, excuse me. They note, and again, 87% of the women in the intervention group who didn't have an MRI said their doctor told them not to have an MRI, so they didn't have it. And then other barriers were cost or put it off. So now we are actually have a funded study, which is a next step. We're doing a digital remote intervention to try to improve those the breast MRI screening rates, which we hope will have an impact where, these are younger women, and hope that this distance intervention will help. We're also trying to activate the primary care doctor as part of this intervention and not just the survivor, because of what I described to you before, that this is an issue with both not just survivor knowledge, but making sure that the doctor is involved too. So I want to conclude on a high note, and that is that we are doing better in terms of the long term with our modern therapies. So our 15% cumulative mortality in the 1970s, 15 years after cancer diagnosis, was almost 11%. In the 1980s, that has dropped to less than 8%, and the 1990s, we're now at less than 6%. This is because we have done a much better job in pediatric oncology at the upfront because of this data, as I mentioned to you. We are identifying those patients that are low risk, and we're reducing their therapies for Hodgkin's, for ALL, and for Wilms tumor. We've also improved in screening and early detection of late effects, as I've shown you. I think we still have a ways to go, but we're doing better. We're also getting better at treatment of late effects and supportive care. So I just want to bring you back to this model for outcomes and survivorship research, where I've shown you that the understanding these survivors ultimately has come back to help us with improving cancer diagnosis and treatment, and now we're improving the outcomes of these cancer survivors. And we hope this wheel continues, because we're continuing with new therapies that we're bringing survivors that we don't understand yet. Dan and I mentioned protons. We don't know the outcomes of how protons are going to affect these patients as compared to other forms of radiotherapy. We don't know how immunotherapy is going to impact these patients, and we're starting to bring them to upfront Hodgkin lymphoma care. We are bringing new forms of therapy for ALL, CAR T cells. We don't know how CAR T cells are going to impact these patients in the long term. So it's imperative that we think about these therapies, not just, again, for treatment, but how we're going to think about them in the long term. So 10 years from now, we're designing studies with that in mind. So in conclusion, I encourage you all to think about a rotation in pediatric oncology, or maybe go into the field, because it's the best area in medicine, because we've gone from these incredible cure rates due to laboratory advances, clinical trials, supportive care, and outcomes research. And that outcomes and health services research is thriving and growing in cancer research. I think, we're even seeing some of this work that we're doing highlighted in this COVID crisis. I received word from the NIH 2 weeks ago that I received an R01, and a part of me thinks it's because it is an intervention to deliver genetic counseling and screening to cancer survivors in their home, which is something that we need to be thinking about more, especially in this era where patients are not going to be going to the doctor. So I'd be happy to answer any questions. I think there's 5 minutes for me and Carol now, and I'd be happy to answer any of your questions. And thanks for your patience. And I apologize, my kids start to rumble in here around the 4 to 5 o'clock hour.
So for the students, so that was a great talk. Thank you. It looks like Carol is still on. So for the students, you can either unmute yourselves or if you want to type in questions. Give them a second. So I don't know if you have the chat box. It says, how easy is it to get more detailed information from old treatments at other hospitals?
Ellen, that's a great question. So this gets to like a resource issue. So I'm particularly lucky in my clinic. I have a nurse practitioner that partners with me. And so whenever we see a new patient coming from an outside center, we say to them, we have to get all your medical records because we want to give you a treatment plan so we can really give you an informed visit. And so some of the onus is on the survivor themselves to go get that treatment, and it's not always easy. There are cases I've seen patients where I don't end up getting it and it's a little more difficult, but we make do, but it can be an issue to get those treatments at other hospitals.
I have a question, just really quick, and then looks like there's another question from Alec, but your talk kind of makes it sound somewhat like it's the physicians not doing a good job keeping track of the survivors, but do you find that the survivors emotionally don't want to stay in touch with the physicians, if that makes sense?
I didn't mean to say it's the physicians. So when I talk about it, most internists are not Carol Rosenberg. Okay. So and Carol chime in if you'd like to, but most internists are like taking care of, 40 patients a day. They have to do asthma, diabetes, asthma, diabetes, name it, Carol, hypertension. Okay. And so to take care of a specialized population that they only see a handful of, it's not something that's going to be hot, that they're just attuned to. So part of it, the onus is actually on the treating oncologist. We need to make sure that the family and the survivor are armed with knowledge, and we need to think about transition more. So we need to be thinking about how to transition patients away as they become adolescents and are growing older. They go out and have some of this information. The way to get to the internists is the primary care physicians is important, and how we get the best knowledge to them at the right time is how we think about it. How do they do a quick search engine search for this information and the right thing pop up at the right time? How do we do intervention studies where we get the right information to them at the right time? When we write to the NIH, we're always saying this is a very special situation where I don't think blanket giving all of this information on a super subspecialized group is something that the primary care physician will be geared toward. I don't know, Carol, if you want to pop in and say something about that.
Well, what I want to say is that this is really my point from the beginning of the lecture, which is that I'm all about conceptual framework. In other words, what the point that I was making in the beginning of our, of the lecture series is, it's first of all, in terms of pediatric oncology, and even in adult oncology, it's impossible for an internist to know and even pediatricians, to know all the treatments for all the types of different cancer. And then, of course, those treatments change longitudinally, like you were talking about in the Hodgkin's context. If you're looking at someone who had mantle radiation, that's totally different from somebody who didn't have mantle radiation, who had a, node-focused or specific area, et cetera. So I really think that the real key is a conceptual framework for which physicians of any specialty can easily go to I think it starts with a treatment history and anticipate what there might have happened. In other words, what might be the reason for them to anticipate that they're all going to have late effects. And what exactly is that? Whether you're talking about an adult survivor of childhood cancer or you're talking about an adult survivor of adult cancer. And I think that really a framework of, and I think Dan's class really highlights that we need to start teaching that conceptual framework very early on in medical school. And it is, I'm a senior stateswoman, as they say, and in my day, when we saw patients as I was a, clinical internist. We didn't send our patients to the endocrinologist for diabetes management. We handled it ourselves. And we need to be able to understand the basic context and the basic way that if somebody had cancer treatment, we need to anticipate. We might not know exactly what that late effect is, but we need to think about it. And then you go to the guidelines, or then you go to the survivorship care plan, et cetera. And the individual who asked, how do you get the record of treatment? I think in the pediatric context, that's particularly difficult if they haven't been treated in your system. But in the adult system, I think now, and I think this is an area which, the electronic health record has really helped in that, we are able to compose survivorship care plans based on treatments received within our system. And then it's up to the patient to get it from another system. So it is problematic, but it's getting better in that.
So Alex, your question about whom do patients view as the main physician in charge of their survivorship care, I think it depends, right? So I think if we go back to our data in the childhood cancer survivor study, if you're talking about adult survivors of childhood cancer, there is a subset that still go back to long-term follow-up programs. So most cancer centers and pediatric hospitals have these long-term follow-up programs, even for adults. So Dana-Farber and Children's Hospital of Philadelphia and University of Washington and UCLA, they have these programs. However, most of the patients are not actually going to those programs anymore. And so I think that the main physician in charge of their care is their primary care doctor,
And their mother.
And their mother, right? And so the primary care doctor, when we're doing interventions right now, is who we're trying to target. And we're trying to think about how we can alert the medical record. I think the problem is we've talked about, wouldn't it be great if Epic is our medical record at UC, if Epic could just give an alert that said this patient had chest radiation, so they need cardiac screening and breast cancer screening. And the problem is that we don't have interoperability in our country. And so when we've looked into primary care doctors on a national framework, if you have like 20 different primary care doctors, you might have 20 different electronic medical records. So when we talk about doing that for all of these primary care doctors, it's not feasible. We talked about doing it for several of our intervention studies, and it's kind of a problem. So what we want to think about from the survivor standpoint, arming them with the information the best we can as we're transitioning them away, giving them mobile information that they can carry with them, and then also think about novel ways that we can alert primary care doctors at the right time. And some of that is with intervention studies that I'm mentioning to you. We are in the childhood cancer survivor study, we're developing an app called My LTFU, so My Long-Term Follow-Up, that is on their phone, alerts them to screening that needs to be done, provides them with education systems, and we want to think about how to disseminate that kind of information. And then, in a pie in the sky way, I wish we could think about interoperability. I just learned this the past couple of years. I did a program with the Bush Institute, which showed us that interoperability was put into federal law under George Bush the First. And that just like blows my mind that people were saying we need to think about interoperability of medical records since the late 80s, and like we're just not there. It would be great if we were, but we're not there.
And I think Tara and medical students that are still listening, I think the most important thing, and in the adult context too, is that we always talk about shared care. And nowhere is that more important than in the survivorship realm, because one of the resources I gave you was promotion of self-management. Patients need to be able to have a document or have an understanding or be taught what it is that they need to look out for. And in the pediatric oncology setting, as they transfer to adult care, unfortunately or fortunately, their associate of engagement, which is usually a parent, has all this history, but we have to teach these transitioning children, now adults, that they need to own their history. And I think that is really one of the real things that we have to do.
And I'll let you go, Dan. I know we're past time, but in England, they have a risk stratified system of follow-up care for adult cancer survivors. And based on what you're exposed to in your primary cancer diagnosis, you go down different tracks of whether you get self-management, total self-management versus followed by the primary care doctor versus a subspecialty clinic. And we've talked about with the American Society of Clinical Oncology and the ACS, we are trying to figure out how we can develop similar models in the US so patients get tracked at the time of diagnosis for exactly what Carol's talking about.
I had one other question for you, Tara. If students need to go, that's okay. But just really quick, next week's reading week, we'll call it. There's no seminars, and then we'll resume the week after. But Tara, if you have time, do you have a couple minutes to talk about what it means to have an R01 and how you applied for that and what it's funding?
Oh, sure. I actually am a physician scientist, I guess. So I decided when I was a medical student that I wanted a component of my career to be not just clinical care, but also research. I think it was one of the things that attracted me to the University of Chicago. And initially I thought I was going to be a lab-based doctor, but then as I was not that into killing animals. So I became intrigued by this idea of doing clinical research. So in order to have time where you're not just seeing patients, you need to apply for grants to protect your time and to pay for these research studies that you're applying for. So an R01 is an NIH funded grant. It's a 5-year grant that pays about $500,000 a year to cover part of your time, your co-investigator's time, and the cost to run a study. It is, to get to the point that you write the independent R01 study, you need to, write papers in the area to show that you've become sort of an expert in that area. A lot of times you need to have like career development grants. So I've had when I talked to you about my physician studies, that was research that I did when I was in my career development award, which was also funded by the NIH and protected my time 70% of the time. So it's you write it, the grant itself.
Is that a K award? Sorry.
What'd you say?
Is that a K award? Because we were talking about that.
K award, yeah.
Dr. Olapade last week.
Who did?
We were talking about K awards with Dr. Olapade last week.
Yeah, so Dr. Olapade was actually one of my mentors on my K award. This is an award you write usually within the first couple of years out of your fellowship or residency training. That again, you are protected for 5 years. You only do clinical work 20 to 25% of the time, and the rest of the time you're doing research. And during your K award, you're really developing methods and areas of your research. You're trying to learn didactic areas that you haven't learned about before. So some people will get a master's of public health or do some didactic training. I had actually done that as a fellow, so that wasn't part of my K award, but I think I proposed as part of my K award that I would learn qualitative research and survey-based research. And then once you have that K award and you finish that, then you apply to these big independent awards. It's a wonderful experience. It's something that you have to be ready to be patient for. And, I think that all of us, people that have gone to medical school, we're used to, doing something and you get an A and you go on and you do the next thing and then you get an A. And writing R01s is a practice in that they only fund 8% of grants right now. So you have to write a lot of them, and you have to develop a little bit of a thick skin and the ability to be patient. So that was something that probably when I was in med school, I didn't have a lot of, but I have developed it since as I've done this work.
I was intrigued. I guess I always pictured R01s as basic science, you know, lab, bench research. And so I'm intrigued that your project, it's not even a clinical trial per se of a therapy. It's a clinical trial of educational interventions. And
yeah, I'd be thrilled to describe the grant on another day if people want to hear about it.
I know you have a babysitter to drive home too, so.
No, it's okay. We're all right. So I'd be happy to anytime. So.
But yeah, for this, I will have to get virtual coffee sometime, the two of us, because I'm curious to talk to you. But for the students too, it's just another example that I'm learning also, but that R01s, which are the kind of premier NIH grants generally for an individual investigator, I learned today, don't have to be bench or, you know, they could be educationally focused. So there's a ton of those options out there. So.
Yeah, usually an R01, well, there's epidemiologic R01s that are lab-based, so you can study epi, and that's not going to be as lab-based, but also intervention trials of behavioral efficacy, you know, behavioral intervention trials, different intervention trials are fundable for sure.